Osteoblastoma, didactic summary. Osteoblastomas are rare, benign, but aggressive bone tumors commonly found in the spine's posterior elements. They typically affect individuals aged 10 to 30, presenting with regional pain that only partially responds to NSAIDs. Diagnosis is made through imaging, revealing a lesion larger than 2 centimeters with a sclerotic margin and radiolucent center. Treatment usually involves curettage or marginal excision, often accompanied by bone grafting to repair the defect. These lesions are rare, comprising only 1% of primary bone tumors and 10% of spinal bone tumors, making them less common than osteoid osteomas. Males are affected more frequently than females, with a male-to-female ratio of about 2:1. The majority of cases occur in individuals between 10 and 30 years old, highlighting a significant age-related prevalence. Osteoblastomas commonly arise in the posterior spinal elements and sacrum, accounting for 30 to 40% of cases. They can also occur in long bones and the mandible. Genetic factors include rearrangements of FOS and FOSB genes, which play a role in the tumor's development. They can be associated with conditions like oncogenic osteomalacia and secondary aneurysmal bone cysts, ABC, with up to 40% showing secondary ABC association. Symptoms are characterized by dull, progressive pain, which is atypically not worse at night and only partially relieved by NSAIDs. Neurological symptoms may occur if the tumor involves the spine, potentially affecting nearby nerves. Physical examination may reveal swelling, muscle atrophy, and a limp, indicating the tumor's impact on mobility and tissue. Radiographic imaging with recommended AP and lateral views can identify a lytic or mixed lesion with a radiolucent nidus. The lesion may appear aggressive, sometimes mistaken for malignancy, but typically has minimal secondary bone reaction. MRI can help assess the lesion's size, location, and any associated soft tissue involvement with specific signal intensity characteristics. Bone scans typically show intense focal uptake, indicative of the tumor's benign but active nature. Histologically, osteoblastomas resemble osteoid osteomas, but have more giant cells and distinct demarcation between nidus and reactive bone. The nidus contains immature osteoid and osteoblasts, with numerous mitotic figures and abundant vascularity. Differential diagnosis includes osteomyelitis, ABCs, osteosarcoma, and differentiating features of each condition must be carefully analyzed. Osteoblastomas lack periostitis unless there's an acute fracture, unlike osteosarcoma, which often has a soft tissue component. Osteoblastomas also differ from osteoid osteomas by their larger size, higher prevalence in the spine, and greater number of giant cells. In conclusion, a thorough understanding of osteoblastomas' distinctive features is crucial for accurate diagnosis and effective treatment.